Neurology Quiz number 119. Describe the etiology, clinical features, investigation, and treatment of chronic immune sensory polyradiculopathy or CISP. Chronic immune sensory polyradiculopathy or CISP is a rare type of atypical CIDP or a CIDP variant. It is an inflammatory immune disorder of the peripheral nervous system. It is characterized by isolated involvement of the dorsal nerve roots proximal to the dorsal root ganglia and typically spares the distal nerve roots. This figure shows the site of involvement in CISP, which is the dorsal root proximal to the dorsal root ganglia and spares the distal nerves. Clinical features. The mean duration of presentation from onset of symptoms was 5 years in one large series. The majority of patients present with gait imbalance, sensory ataxia, and falls. Other symptoms include numbness and paresthesias, which usually begin in the legs. Initially, these symptoms may be asymmetric, but gradually worsen and spread proximally in the lower extremities and then to the arms and become more symmetric. Examination reveals large fiber sensory loss in the extremities with reduced or absent reflexes. There is greater involvement of the legs as compared to the arms. Muscle strength is preserved. Investigations. Nerve conduction studies and needle EMG are typically normal due to selective involvement of the proximal sensory nerve roots and sparing of the distal nerves. Tibial H reflexes may be absent. CSF shows elevated protein in the majority of cases without increase in the number of cells. MRI lumbar spine with contrast can show enhancement and thickening of the lumbar nerve roots. Figure A and B are T2 weighted sagittal MRI images showing thickening of the nerve roots of the cauda equina in a patient with Guillain-Barré syndrome. Similar findings are noted in CISP. This is the same patient. Sagittal contrast enhanced T1 weighted images are showing the roots of the cauda equina are diffusely thickened and enhance uniformly. Somatosensory evoked potentials are important in establishing the diagnosis. Tibial nerve SSEP abnormalities are reported in more than 80% of the cases, signifying proximal nerve root involvement. Median nerve SSEPs are reported to be abnormal in about 50%. Nerve root biopsy, when performed, has revealed marked reduction in large myelinated fibers, lymphocytes and macrophages in the endoneurium, and onion bulb formation. These are median nerve somatosensory evoked potential tracings from a patient with CISP. Slowing occurs before the cervical spine site, which is N13, and within the segment between the clavicular and the cervical spine sites, which is N9 to N13, and the segment contains the sensory root. These findings show that slowing primarily occurs at the sensory root level. This is a dorsal rootlet biopsy showing onion bulb formations in the form of thickened strands of multiple Schwann cell processes surrounding the nerve fibers. This is from a patient with CISP+. Similar findings are noted in CISP patients. Differential diagnosis in such cases includes sensory CIDP, sensory neuronopathy, dorsal column pathology. As patients present with ataxia and unsteady gait with normal strength, they may be labeled as having a functional gait disorder. Treatment reports in the literature indicate that patients responded to both steroids and intravenous immunoglobulin. Treatment regimens have included IV solimedrol for 5 days followed by PO prednisone. with IVIG. An initial 5-day course is followed by repeat doses at monthly intervals. Response to treatment can be monitored by clinical improvement of ataxia and ambulation, as well as by reappearance of deep tendon reflexes and improvement of sensations. Tibial nerve SSEPs have also been used to monitor response to treatment. Rare cases have been resistant to both treatments and required alternative immunosuppressives such as mycophenolate. CISP plus. Some patients present with a clinical syndrome similar to CISP and have disease that extends beyond dorsal nerve roots to involve motor and postganglionic sensory nerve fibers. This results in mild distal weakness and mild abnormalities on nerve conduction studies and EMG. These patients cannot be classified as CISP because their disease is not isolated to the dorsal root and do not exclusively have sensory symptoms. They also do not meet diagnostic criteria for typical CIDP or sensory CIDP, which require demyelinating abnormalities on nerve conduction studies. Such patients are labeled as CISP plus and are managed similarly. This is a classification of CIDP and its variants. A is typical CIDP, which is a subacute and chronic, symmetric and proximal and distal weakness, as well as sensory loss and areflexia. Clinical nadir is reached after 8 weeks. Then B is atypical CIDP or CIDP variants. And number 1 is acute CIDP. In 20% of patients, the disease starts acutely, mimicking GBS. Although clinical nadir is reached within 8 weeks, patients have a relapsing or progressive course, which differentiates them from GBS. Number 2, sensory CIDP. Symmetric sensory predominant presentation with sensory ataxia and generalized hyporeflexia/areflexia. However, motor and sensory nerve conductions show evidence of a demyelinating neuropathy, and this may evolve into a typical CIDP. Number 3, motor CIDP, symmetric proximal and distal motor deficits. This accounts for 5 to 10% of CIDP. Number 4 is MADSAM, or multifocal acquired demyelinating sensory and motor neuropathy. This shows asymmetric weakness in sensory changes. Reflexes may be normal in the unaffected limbs. EMG and nerve conduction studies shows multifocal demyelination in motor and sensory nerves. Number 5 is DADS, or distal acquired demyelinating symmetric neuropathy. This is discussed in quiz number 14. Number 6 is focal CIDP. This is rare and presents with symptoms localizable to brachial or lumbosacral plexus or nerves of one limb, manifesting with motor weakness and sensory changes. On EMG and nerve conduction study, motor and sensory nerve involvement is present but is restricted to the clinically affected limb. Number 7 is CISP, and number 8 is CISP plus. This figure shows the spectrum of CIDP and its variants, as well as other chronic demyelinating neuropathies and GBS.